So Ziad and Saiba are going to moderate the first session. The first session is on atrial interventions, and Lee, that was a great talk. One of the things I think about when I started actually was getting comfortable not only doing a complex procedure, but also having to have a fellow there and getting comfortable with them being able to do the procedure with me. And I find that's even a bigger challenge when you start. I don't know if a lot of you have fellows who work with you, but for me, that's always a very delicate balance. So my comment to that is you really do have to find a balance because your reputation is only as good as your last case that you do. First session is on atrial interventions, and I'd like to introduce our first speaker. John Carroll, who was here last year, who is an expert in this field, and he's going to be giving us a couple of talks today. And the first talk, we thought his expertise, because of his knowledge and equipment and some of the novel things that you're doing with some of the companies in industry, you'd be the appropriate person to talk on the subject. So we're really excited to have you. So he's going to talk on the state-of-the-art imaging and equipment and techniques and what you need in your lab.
Are there any solid data associated procedure-related radiation to late onset malignancy? No. The data are mixed? Yes. Post-PCI?
The Wi-Fi is not connecting. Shit, it's not coming.
Okay. The data are mixed.
Okay.
All right. Next.
No. Or do you want to show the correct answer or no? Or do you come to the...
There are 3 questions for you, right?
Okay. Do you come to the answers in your talk or no?
We'll see.
Okay.
Okay. Intra-procedure C-arm CT imaging is commercially available, an R&D project, not a potential alternative to pre-procedure CTA, is a feature of all X-ray systems sold in 2018. Too easy of a question, perhaps. All right, finally, echo fluorofusion can help in image guidance for which of the following interventions? PVL closure, pulmonary vein stenting, MitraClip, all of the above. Can I sit down now, Eric? I mean,
That's it.
yes, that's it.
Your flight leaves in 30 minutes.
All right, say 2. All right, this is my advancer, I take it. All right, are we ready? All right. So I do have a conflict. For about, it's almost 20 years, we've had a close working relationship with Philips. And it's really been good. And if you have the opportunity for industry collaboration, it has its challenges, but it's really fun working with engineers. And in imaging, it's important because it's very rapidly evolving, and it helps you stay up. So I think you have to talk in imaging about the priorities, and the first is having an X-ray system that has the lowest possible radiation dose, plus operators who know how to use it and reduce that. And here's a nice terrible lesion. I've never seen one that I think I've caused, but when do these occur? Is it the day after the procedure? No. So it's often weeks, months later, and they may never even come back to you and think it was related to that, to the procedure you performed. So a new guideline mainly deals with improving your technique but the technology is also very important. We have multiple labs, and the radiation dose received by patients varies hugely, and that's a great concern. This is a Canadian study. If you look on the first column are cases who had malignancy and the control group, and down below shows the risk factors or the associations. Again, it's not causality necessarily, but a lot of procedures, a lot of x-ray based procedures, early in life has an association with later malignancy. And that's extremely sobering, especially for people who are treating younger patients. We kind of blow it off when we're treating an 85-year-old because the malignancy associated with radiation is really decades down the road. But it's very, very sobering because it's what we've done before has long-term implications. So there are a lot of features that come in the X-ray systems that you should learn how to use. And some of them are very simple, like being able to archive an image that's acquired with fluoroscopy, which much less radiation than using cine. So keep your foot off cine pedal as much as possible, because fluoro quality has come up so much that you can do a grab of that. Also, I think I learned from electrophysiologists who were dealing with EP procedures that went on forever that you could really reduce frame rates and still do many things. Yes, it's a little jerky, but when you look at the radiation reduction, it's huge. Huge. What about rotational angiography? So Siemens has really led this with DynaCT. And it's a fascinating approach to using a flat detector it is really a surrogate for a CT scanner once you start circling it around the patient. So it requires a rotational image acquisition, and it does have some uses in terms of replacing the need for a pre-procedure CTA used for planning procedures. And this shows one of their applications where it's a rotational angiogram of an aortogram with 3D reconstruction, and then you can register that on a live fluoro image on the right and allow it to help you guide placement. Perhaps not so critical in TAVI or TAVR, but it really shows how this technology's come along. It's predominantly used in vascular interventions, but because it's hard to do this with a moving object like the heart, but it can be done, and the registration can be done such that the overlay is dynamic. This is a fascinating image, and yeah, Saibal, you can tell me what device that is. This shows the amazing ability to reconstruct cardiac devices by using rotational fluoroscopy and with an algorithm that does 3D reconstruction. So this was not in a patient. We placed this just on the X-ray table, did a rotational acquisition, and with the 3D reconstruction algorithm that several vendors have developed, look at that spatial resolution. It's just incredible. You could pick up fractures, etc., of devices. So rotational acquisition has a lot of different applications that you should consider. And we've done some of this in like a mitra clip. You can reconstruct that in a patient. So it's an insight into the future of some applications. So priority 2. Cath labs were X-ray based for eternity. But now it's reasonable to think about a new paradigm. How would you design a lab that predominant imaging modality was ultrasound? And in fact, I've been to a couple presentations, one at PICS, where a Chinese interventionalist presented really good data on being able to do a variety of interventions with only ultrasound. So think about that in your future cath lab. So 3D visualization in ultrasound really happened with TEE. And this is an amazing image, a couple years old, that just shows how spatial understanding is enhanced by 3D image display. And it really, this is a left atrial image of someone about to doing a transeptal. The next generation, this is from the X8 probe, and I'm not sure how well this projects, but if you look at the 3D down below, you see a prosthetic mitral valve and doing a paravalvular leak. The next generation TE systems have about a 50% improvement in spatial and temporal resolution. It really allows us to see things much better. Whether it'll come into the pediatric probe sides, I don't know, but this is a probe we just acquired and started to use recently. So next, we're using multiple modalities, and you have one modality in one screen and the other on the other screen, and it's up to your brain to integrate the two. And of course, like a TE image, the view from the esophagus is very different from a fluoro view, where it's a view from a frontal plane. And so you have to do the mental geometry, you have to do the acrobatic thing of switching them around. Well, echofusion and for fluoro is a way of getting around that, and it's a very novel technique that has been steadily growing. Multiple vendors do this. We've been working with Philips. But basically it shows here you take the two data streams and in a workstation you integrate that. How does it work? Well, it works mainly through the registration, that is the matching of the two imaging modalities, and you have to have a common landmark, and the TE probe in X-ray allows you to recognize that and the orientation of the TEE in an X-ray image, and since it's known where the 3D data set from the ultrasound will be relative to the head, that's the way that registration process works, and it's automatic. It automatically recognizes the orientation of the TE probe. I've been pushing for it to happen with ICE, but realize that you've got to have an interface of the tip of the ICE probe that can be recognized automatically by a algorithm and the orientation, but that's probably going to happen. This is a short movie of using now kind of next generation echo fluoro. So here you see doing a transeptal with an overlay is amazing. And now automatically you can generate a model of the chambers, and you really start understanding the diversity of how the heart is oriented in the chest, how the plane of the septum is different from patient to patient, why you have to put a bend in the transeptal needle in one person, but it's actually much straighter. And so the models help that understanding. And look how horizontal LA-LV is in this patient. So often when you're doing these mitral interventions, you have to deal with this inherent difference. Here we're, so you can automatically, the algorithm can recognize where the left atrial appendage is, and so steering up into the left pulmonary vein is not something you do kind of blindly where you're in and out of the left atrial appendage, but with an overlay you can go up there. Now there's an algorithm that the model has created of the mitral valve leaflets. So helps you, where's A2, P2, automatically you can see those leaflets, and so when you're steering, it gives you on one screen all the relevant information. And so you go to ARIO and you can lay out the plane of the mitral valve in a way that you just can't in a very patient-specific way. So we're using this quite a bit for mitral interventions, a variety of kind here. The models aren't perfect, but they fit the patient's anatomy as much as you can see, but of course in TEE often you don't see the roof of the left atrial appendage, so you got to be careful about that. It's kind of a challenge we have between the interventionalists and the echocardiographer gathering it, of declaring where is the residual jet in MR. But you can see in the right image, the overlay, you can see if it's above, it's going to be more lateral. If it's below, it's more medial. And so you get this immediate feedback. And so overlay is not only about the 3D image, it can be about 2D echo, and it can be about Doppler. The color flow, and doing a pulmonary vein stent, trying to maneuver to a pulmonary vein is so much easier if you've got a live fluoral image where you've got the color flow image right overlaid. So it really enhances the ability to perform certain tasks much more efficiently. So it's one real-time fused image, and so it's different from CT fluoro overlay, where the pre-procedure CT is static. These are two live imaging modalities that you can overlay. You harmonize the perspectives, so you're not doing those geometric manipulations, and it's all about what we do, eye-hand coordination of making that easier. So you manipulate things much more efficiently. Next priority, so I'll have to stop and editorialize. 20 years ago, we had much greater say when we wanted a new cath lab in terms, and running cath labs in general. Now, depending on the healthcare system, you may not have much input, and you really have to make a case for adding these features because they are expensive. So one of them is image display. Big screens, holography is coming. It has been coming for about 10 years. And next generation 3D display, I'll show some. So I don't know. Thinking back, we were standing here doing interventions, and we had this little screen that was about 4 feet away. It's a terrible dynamics. Just think about putting your PC screen that far away and working. That's what we were doing. So it was wonderful with the big screen technology coming along, and it was not only because of the geriatric interventionalists not being able to see very well, but it really helped put multiple displays and the ability of different images and the ability of showing things. So it really, I think, is an essential feature for 2018. So this is a fascinating image. So this is a 3D TE image of a prosthetic mitral valve where there are 3 paravalvular leaks. The traditional display of 3D images has used a technique called pseudo-colorization, where blue is deeper, tan is more close, right? So you had to learn that. And that's inherently not the way the human visual system evolved. So we're going from that traditional to a new technique called illumination. And that's backlighting, where the source of light is behind in the LV. And just look how the paravalvular leaks jump out at you. Backlighting is something photographers know is a very effective technique for enhancing contours. Illumination is the way we look. Human visual system works by illumination, not by pseudo-colorization. So with this new feature, you can move the light source in different ways. You create shadows. You enhance contours. It's really, I think, a fascinating technique, and it's all about image display and being creative about what comes next. So imaging is rapidly evolving, and our needs are rapidly evolving. Unfortunately, it's not like a device, it's not like a commodity you can restock. It's a capital purchase. And capital purchase, as I said, sometimes we have less control over, but it's very important for you to have that relationship with your hospital administration, because the future of how well and what you can do interventionally is now tightly linked to what kind of imaging technologies you can bring in and go up the learning curve of how to use them, because some of them are more complex, and so there's a learning curve associated with that. So bottom line, invest wisely, because these are very expensive purchases and you're stuck with them for 10 years or more. Thank you.
Great, thank you, John. That was good. So we have actually room for a couple of questions because, you know, the schedule left like 5 minutes in between each talk, so I assume this is for quick questions, but then at the end we will have discussions. So question there.
The amazing illumination picture, was it done by a machine or was it post-processed by some imaging tool?
It's real time. And it's relatively new, so we really don't understand how to use it, and it's something everyone should think about. Where would you, if you want to interrogate an object, where would you put the light source? And so there's that flexibility of moving the light source away, also the distance, and so it's early on in using this, but it's broader than cardiac. To me, it makes a lot of sense. It's inherently easier for us to understand images that are created with an illumination rather than a pseudo-colorization. So we'll see how it evolves and becomes available, but it is real time. It's not a post-processing.
Yeah, that would be great.
Yeah, sure.
John, it's just a button on your machine that you press and it does that automatically?
It's, yeah, you can switch between the two different ways of, between the pseudocolorization and the illumination. So, you know, one of the problems with new imaging technologies is how do you validate their clinical worth? It's a hell of a challenging problem. A lot of it is more Likert scale. Well, I think it looks better. I think it's more useful. I'm hoping with this sort of thing, if we had a gold standard for like, you see paravalvular leaks, not only their size, but their shape. And so, you know, we need a gold standard to see if this is more accurate than other ways of displaying.
Just one more question.
All of the above. It's, I think Lee's talk about relationship building in general also goes toward hospital administrators. Our relationship with Philips was solidified when our hospital COO got on a plane with me and we flew to Netherlands together. And she, you know, saw the technologies, met the people, got into, hey, imaging is important for how well we do things. So you have to have that kind of buy-in and a relationship because it's hard to, as I say, using new technology, why my complication rate goes down. You can sometimes come up with some data like radiation doses go down, time to perform a certain task is reduced, and those are meaningful endpoints, but it's in general a challenge of showing one imaging technology change on the an outcome of an intervention that involves a lot of different aspects, and there's so much patient-to-patient variability that you'd have to do large studies to kind of equally distribute the complexity of, especially in a pediatric and adult congenital intervention.